2 of the video about abnormal uterine bleeding. Part 2 will consist of focus further on heavy menstrual bleeding, and in particular what are the diagnostic steps we usually take to find out what is possibly behind the heavy menstrual bleeding. Next we discuss the so-called unexplained uterine bleeding. Then a very important topic, what are various management options, expectant, medical, surgical, and we finish with a summary. The diagnostic workup for women presenting with heavy menstrual bleeding, or as it was called in the past, menorrhagia. I think we always should include a combined transabdominal and transvaginal ultrasound scan. This gives us not only a reliable impression of the measurements, the total measurements of the size of the uterus and the volume, but also we can count the number and dimension of the fibroids and their location, and we can visualize and measure the endometrium. That's important as well for follow-up to see whether there's any changes. We can look at the content as well, and what is good, the experienced eye is very good at pattern recognition. A fibroid uterus has a typical appearance. And of course, in our differential diagnosis, we have to be mindful that we could deal with an ovarian malignancy or ovarian tumor, or a surprise pregnancy, which presents with an enlarged uterus as well. And especially in an exam, that could be a confusing situation, so make sure that you exclude a pregnancy. This is a few pictures now of a transvaginal ultrasound scan. This is an example of a lady who is 37 years of age and presents with heavy menstrual bleeding. We see here one, and here a second, and there is a third fibroid. So this lady has a uterus with, at least in this section, 3 fibroids. And the diameter is 3.8, 3.0 and 3.3 centimeters. Ideally, the measurements should be 3-dimensional, which gives us a very good impression of the volume. This lady, another section. Now we have a transverse section. Here is the uterus, and this is most likely a subserous fibroid. A fibroid which is protruding from the outer surface of the uterus. Here an example of a lady of 49 years of age with heavy menstrual bleeding, and we can see here a single fibroid, and here we see beautifully the 3 dimensions, 2.47, 2.36 times 2.41 centimeters. A single fibroid which is mainly submucous and intramural in the wall of the uterus. How does a uterus with fibroids look like? Macroscopically, with a naked eye, we see here a uterus which has partly been removed through a phalansteal incision during an operation. This is the body of the uterus itself, and here we see numerous subserous fibroids protruding from the surface. I think here you can see the round ligament. The diagnostic workup. What do we further need to investigate? In my opinion, a full blood count checking the hemoglobin and a serum ferritin will inform us whether this lady has an iron deficiency anemia, confirming truly that her periods are too heavy or too prolonged to keep up with. I would think only if the history points at specific issues. We should of course do a beta ECG in case of doubt, and usually checking the hormones only if there is a pointer in the history. Clotting status the same. In a lady with a second who commenced to have heavy bleedings at the age of 40, Van Willebrand quite often is negative, so only if need be. What additional investigations. Endometer sampling, yes, keep that in the back of your mind, especially if women are older than 45, we have to be mindful of endometrium pathology. The chance of endometrial cancer, by the way, is less than 1% if a woman is younger than 50 years and increases to 10 to 15% to 10 to 15% after if she's older than 50. I would like you to refer to the 2 dedicated DAROGA videos about postmenopausal bleeding. And particularly in part 2, I address the risk factors for endometrial cancer. Hysteroscopy, again, if the uterus, if the ultrasound scan shows an irregular endometrium, if there is a suspicion for submucous fibroids. But here we should consider the age, risk factors for endometrial cancer as discussed in another lecture. Thorough inspection of the uterine cavity, of course, is possible when we perform an hysteroscopy. We can also take directed biopsies from the endometrium, and if we find a submucous polyp or fibroid, these can be removed quite easily. Sometimes we can add and combine the hysteroscopy, the DNC, with insertion of a progesterone releasing IUS, a Mirena. Submucous fibroids, we see here on the left hand side, in the left panel. This is the submucous fibroids. Here we see the uterus, which appears to be retroverted. This looks like the endocervix. How does it look like in case of an hysteroscopy? We are now with the hysteroscope in the uterine cavity. The cavity has been distended with normal saline. We see here the uterine cavity itself, and this round structure is a fibroid which was pedunculated and could be removed quite easily. Of course, understandable, this type of fibroid, a submucous fibroid, protruding in the uterine cavity can not only contribute to heavy menstrual bleeding but also painful periods, dysmenorrhea. Another chapter now is the unexplained uterine bleeding. This is quite often still described as dysfunctional uterine bleeding. I rather avoid that term, especially when a patient is present, because that could be misinterpreted. So I would prefer to use the rather neutral term unexplained uterine bleeding. And of course, heavy uterine bleeding is quite often unexplained because our understanding of the basic mechanism is still quite limited. The diagnosis is a diagnosis of exclusion. So a woman presents, for instance, with heavy menstrual bleeding. We are unable to find any fibroids. There is no clear indication for any other untoward situation. So we exclude most common conditions as discussed in these videos. And so the woman still wants us to do something about it. In principle, 1/3 of the women presenting with abnormal uterine bleeding are classified as unexplained. Is it an increased local prostaglandin E2 production, or is it has to do with the prostaglandin F2 alpha ratio? Is it a defect in the fibrinolysis, or is it a partial anovulation or corpus luteum defect? We really don't know. What are the management options? Well, before we decide what option is probably to be recommended to a lady in front of you, there are 3 important questions to ask. 1, is childbearing completed? Does she still want to have children? And that's quite often related to her age. Secondly, if there's no underlying pathology. Thirdly, what is the quality of her life? So that's the most important question. How bad does the bleeding pattern affect her quality of life? And of course, can we substantiate that with an iron deficiency anemia? Because that's probably the litmus test of heavy menstrual bleeding. Here are the options we can choose from 1. Expectant management, 2. Medical, 3. Surgical, and 4th, angiography. Medical management, we can offer non-hormonal medications, tablets, or hormonal. Surgical, we can conserve the uterus, or we remove the uterus in hysterectomy. Let's go through these 4 chapters separately. I see quite regularly women in my gynae clinic where the bleeding is not too bad, does not affect the quality of life, there's no iron deficiency anemia, in a woman who is maybe 48 years of age, and explanation reassurance quite often works. Women quite often are concerned when they find out there is a mass or there is a tumor. Even when they hear about a fibroid, they are quite often concerned that they might be dealing with a malignancy. So ask her the question, what is going through her mind, what it means for her, and you can explicitly explain and reassure her. I would usually recommend follow-up, for instance, after 3 or 6 months, repeating a transvaginal, transabdominal ultrasound scan to remeasure the uterine volume and, if applicable, the size and the number of fibroids. If everything is stable and the symptoms are acceptable, well, continue to wait is an acceptable option for a few women. What medications do we have? Non-hormonal, non-steroidals are available over the counter. Many are available. For instance, methylamic acid or naproxen, 250 to 500 milligrams, twice to 4 times a day. Ibuprofen, up to 6 to 1200 milligrams a day, and there is no evidence that one NSAID is better than the other, so the most affordable one is probably the way to go, or if a woman has a personal experience with one of these with the minimum number of side effects. NSAIDs result in roughly 30 to 50% reduction in the menstrual flow, and it has a positive effect on menstrual plane as well. So if dysmenorrhea is present, this is probably the number 1 choice. A little slide to explain how NSAIDs work. We see here the production of prostaglandins, fatty acids. The enzyme phospholipase converts this to arachidonic acid, and cyclooxygenase, that enzyme, makes sure that the prostaglandins themselves are produced. Prostaglandins are produced not only in the glandular epithelium, in particular the prostaglandin F2 alphas, but also the PGI2 and the PGE2, prostacyclin and the are vasodilatators, are more produced in the stroma cells and the superficial endometrium. But anyway, NSAID works, blocks this enzyme, so it blocks the prostaglandin production, and that's why they have an efficacy on the heaviness of the bleeding and the pain. A second non-hormonal drug is an antifibrinolytic drug. This promotes the fibrinolysis, which means fibrinolysis breaks down the vascular clot of the endometrial end arteries, and as part of heavy menstrual bleeding that could be broken down prematurely, and this drug actually makes sure that doesn't take place too quickly. The enzyme involved in this are plasminogen activators, PAS, and one drug available on the market is tranexamic acid, which inhibits that plasminogen activator enzyme. It's known as well as cyclocapron, 500 milligram tablets, 1 or 2 tablets 3 times a day, and it's known from research data that this reduces in up to 50% decrease in the menstrual flow. The good thing about these drugs is that both these drugs can be used only if need be. So non-steroidals and cyclocapron can be used only if the periods are heavy or very painful. And some women have objection to take hormones, so that would suit their needs. Medical, now we go to the chapter medical treatment, hormonal. The combined oral contraceptive pill is not only good at suppressing the ovulation, that's the primary aim, it has the pleasant side effect that it reduces the menstrual flow to about 50% as well. We have different progesterone-only regimens. One of them is the Mirena, an intrauterine device which releases slowly about 20 microgram of levonorgestrel per day. It can be inside you for 5 years and can result in a reduction of the menstrual flow up to 80%. So this is a drug which actually has resulted in a considerable reduction in hysterectomies in the last 15 years. Here you see a picture of the intrauterine device. These tips should be placed in the cornea of the uterus, in the uterine cavity, and this white rod is the slow levonorgestrel releasing part of the IUS. Implanton, subcutaneous rod releasing estradiol and other progesterone, however, can result in breakthrough bleeding, and of course then you're up the creek because it's not so easy to remove the implanton, but it's an option. And good is that the compliance is not an issue, both with the Mirena and implanton. Cyclical progesterone has been described in the literature. Personally, I think many women find it a hassle and it's not very effective, so it's most certainly not my first choice. The same applies for Depo-Provera medroxyprogesterone acetate IM, 3 monthly. Compliance is an issue because women don't like injections quite often, at least in the practice where I work. There's even needle phobia. Can result on one hand when you take them Depo-Provera in breakthrough bleeding. On the other hand, when the Depo-Provera is discontinued, some women suffer from prolonged secondary amenorrhea. So not my first choice as well. Let's continue with a few other options. I just mentioned them quickly. GnRH analogs, they suppress LHRH, they suppress LH and FSH, so the woman arrives in a hyperestrogenic status, as if she is postmenopausal. Hence, she will have menopausal symptoms, she will suffer, the osteopenia, osteoporosis will commence. So, not very attractive to prescribe these drugs, only temporarily in certain cases, I would say. A new drug is now a selective progesterone receptor modulator, and I've seen a few publications of that. This drug is not yet available in Australia, but has in 2 studies published in New England Journal of Medicine, has favorable research findings, so watch this space. Then surgical. Firstly, let's look at uterus sparing. A woman still wants to conceive or wants to conserve her uterus. We can, if there are fibroids present, perform a myomectomy. That can be done either laparoscopically or via laparotomy, depending on the number and the size and the experience of the operator. This is useful if we're dealing with subserous and partly intramural fibroids. Of note is that an open or laparoscopic myomectomy, a pregnancy following this procedure, usually the recommendation to perform an elective cesarean section because of the scar in the uterine wall. If a fibroid is predominantly located and protruding in the uterine cavity, so a submucous fibroid, it can be removed hysteroscopically. Here we see a picture on the right hand side, an hysteroscope, and here at the top we have the resectoscope, which allows us to, by dissecting and by coagulating and cutting, to remove this fibroid very carefully. Another option, surgical option, especially for women with unexplained uterine bleeding, is the endometrial ablation. We aim for destroying the lining of the uterus, and nowadays we have 2 second-generation non-hysteroscopic techniques available I would like to present to you. The first generation is mainly hysteroscopic techniques by which we would resect or coagulate the endometrium. That's no longer used. We have now less invasive and safer options. The endometrial ablations nowadays can be done on an outpatient basis on day surgery. The procedure itself takes less than 10 minutes, and women, roughly 40% have an amenorrhea after 12 months, and 80% are satisfied with an improved bleeding pattern. So you could argue they have a new menorrhea. They're happy about their periods. The endometrial ablation makes sure that this lady has reliable contraception, because a pregnancy after endometrial ablation could be fairly complicated. On the left hand side we see two thermal balloon techniques. The balloon is inserted in the uterine cavity. A clever device heats it up to 87 degrees for about 8 minutes, and that's sufficient to irreversibly denaturate or destroy the lining of the endometrium. Here we have another balloon. Here we see the balloon slightly inflated, and this is the device. This is the so-called terma choice technique. On the right hand side we have a technique which is also used in Australia. That is the bipolar radiofrequency ablation. A very clever copper mesh is inserted and opened up in the uterine cavity. This is the mesh at the tip of this device. Various ways to check that the device is in the uterine cavity and has not perforated through. And we measure the length and the width of the uterine cavity, and this computer generates a certain amount of energy, which with the same effect, it coagulates, it heats the endometrium, and the aim is to destroy the endometrium completely. Hence, if these procedures are successful, then women would have a complete amenorrhea. They would not have periods at all anymore. So interesting that we have the Marina device and the ablation as hysterectomy avoiding strategies nowadays. If, however, the woman opts for an hysterectomy, or if these methods fail, I usually prefer a step-up method. First Marina, if that fails you go to the ablation, and then last but not least we can perform an hysterectomy. Hysterectomy, of course, the advantage is that this will result in a definitive, guaranteed solution, no more bleeding per vagina whatsoever. However, the lady has to undergo a procedure, either vaginally if the uterus is not too big and there is a reasonable descent into the vagina. Second, total laparoscopic or robotic hysterectomy. Total abdominal hysterectomy, which is the most invasive of the three. And depending on the size of the uterus, a midline incision, where in principle you can remove any size uterus, and a phalansteal incision, as the picture I showed to you before. If the uterus is mobile and not too big, a phalansteal incision will give us sufficient room to remove the uterus in total. Here's the specimen I showed to you before. This is the left hand side, just a little glimpse of the phalansteal incision, and we were just able to remove this very big uterus through the phalansteal. I personally prefer to do a phalansteal whenever possible, because it has on one hand a better cosmetic effect, and two, it tends to heal much better and has far fewer complications than the infamous midline laparotomy. The last option I want to mention briefly, with angiography we can perform a so-called uterine artery embolization, by which a catheter is inserted through the iliac artery and find the internal iliac artery and then the uterine artery, and polyvinyl alcohol particles can be released, which result in occlusion of the uterine artery. An Australian audit published in 2012 showed promising results. Efficacy was high. Menorrhagia, for menorrhagia, the efficacy was 96%. For dysmenorrhea, 75%. and 50% for urinary symptoms. Not very clear to me why. The procedure was described as safe. Most studies showed efficacy between 70 and 75%. A publication in the American Journal in 2011. We need to realize that this is a new technique, and of course what has been published could be subject to publication bias. So it's interesting, promising, but not yet part of mainstream treatment. Here we see a picture, the external iliac artery, Stellinger technique, and the internal iliac artery and the uterine artery, and here is where the particles are being released. That's visible here. Good. For symptomatic fibroids and adenomyosis, it could be an option, and for women who want to avoid major surgery and who want to conserve future fertility. So as I've discussed, interesting development, but not yet mainstream. The abnormal uterine bleeding. What is now the best treatment? We discussed a few things. The patient's quality of life, her future fertility, desire and age. And what we need to realize, that the uterus is different from an appendix, that it has most definitely a distinct emotional value. It's part of being a woman. And so we should never underestimate that. So personally, the uterus, removing the uterus should be the last resort. And in my personal opinion, if the woman tries least invasive option first and they failed, she will be very motivated to undergo the final treatment. Last but not least, the doctor's experience will play a role. His or her beliefs, his and her experience, and also the way he or she is remunerated will subconsciously sometimes influence the doctor's advice. In summary, abnormal uterine bleeding is a frequent presentation. Take a history, and as we discussed, what type of problem the woman presents with depends very much on her age. Especially post-menarche and premenopause, the hypothalamus pituitary ovarian axis seems to be not working very well. The diagnosis, examination, pap smear and swabs need to be taken into consideration, and for us, transvaginal and transabdominal ultrasound scan are the most reliable diagnostic tools to make up our minds. Consider an outpatient endometrial aspiration if there are any risk factors for endometrial cancer or hyperplasia. Hysteroscopy and DNC can be combined with the insertion of a marina in case of women who present with abnormal uterine bleeding, especially attractive if they're older than 40-45 years of age. Many treatment options are available. Expectant management means explanation, reassurance and follow-up. Medical, we discussed 2 non-hormonal options, various hormonal options and the pros and cons, and then an operation. Minimal invasively, just remove the fibroid, or perform an endometrial ablation, or finally perform an hysterectomy. And as an option to keep in mind, nowadays in certain centers uterine artery embolization is available as well. That concludes part 2 of this very important and hence somewhat longer than expected video, part 2 of abnormal uterine bleeding. Thank you for your attention.